Good evening, everyone. Today we have a very interesting topic that is low gradient aortic stenosis. This talk will be focusing predominantly on evaluation. It will be a case-based scenario with relevant updates from 2020 ACC/AHA guidelines. So let's get started. This is scenario one, a 60-year-old gentleman with a history of chest pain on and off for the past 1 year. Echo findings, as we see, we find a thickened calcified aortic valve with restricted opening, turbulence and color flow Doppler, and a fairly good LV function. So valve area as expected is less than 1 square centimeter, EF of 55, and a gradient more than 40 millimeters of mercury. So diagnosis would be obvious. It is severe aortic stenosis, and the management is as per recommendations, it's aortic valve replacement. That was pretty straightforward. Now we have the second scenario. This is a 55-year-old gentleman who is a hypertensive for the past 3 years on optimal medical management, now with controlled blood pressure. He's got chest pain on and off for the past 1 year. And his echo findings are bicuspid calcified aortic valve, again with restricted movements, turbulence on color flow Doppler, and a fairly good LV function. So valve area as expected is less than 1 square centimeter, EF of 54. But what is surprising is his aortic velocity is less than 4 meters per second and the mean gradient is less than 40 millimeters of mercury. So what will be this patient's diagnosis? Is this going to be severe aortic stenosis, moderate aortic stenosis, or it's just a measurement error which is giving rise to the discrepancy between the valve area and the gradient? Or does this case demand a more detailed evaluation? Well, I would say this case demands a more detailed evaluation. So before we get started with the evaluation, just a quick recap of the stages of aortic stenosis and a word about the etiology. So we have 4 stages. B, progressive, includes mild and moderate. C is severe asymptomatic. D is severe with symptoms. And severe aortic stenosis as such is just a spectrum, which includes both high gradient and low gradient. Under low gradient, we have 3 entities which are based on the ejection fraction and the flow or stroke volume index. EF less than 50% is classical LFLG. EF more than 50 based on the flow can be either paradoxical low flow low gradient or it can be normal flow low gradient. A word about the etiology of this severe aortic stenosis. As you all know, this you must be familiar, classical LFLG. Aortic stenosis, it's a chronic pressure overload, hypertrophy of cardiomyocytes, impairment of coronary vasodilatory reserves, subendocardial ischemia, cell death, declining systolic and diastolic function. Something more interesting is this paradoxical LFLG. Is it possible for a patient to have a tight aortic stenosis and a good ejection fraction, but still have a low flow and low gradient? Yes, it is. The reason is here. There is pronounced concentric remodeling, which is giving rise to impairment in left ventricular filling due to restrictive physiology. So the problem is LV filling rather than emptying, along with subtle impairment in longitudinal systolic function, which we are not able to pick it up by ejection fraction. So these 3 factors contribute to reduced forward stroke volume, low flow, and ultimately low gradient. So as we see, this shares many features similar to heart failure with preserved ejection fraction. Most of the patients are of older age group, females with history of hypertension. And we see one more parameter here, which is ZVA, which is valvuloarterial impedance. AS is a degenerative process. Most of these patients are hypertensive. LV is actually facing a double load, one at the level of valve and other at the level of vasculature. So an estimate of this entire or global LV hemodynamic load is ZVA. In paradoxical LFLG, the value is invariably elevated and a cutoff value more than 4.5 is an indicative predictor of mortality. The implication is, before you got to assess the severity of AS, always do a blood pressure measurement and ensure that the blood pressure control is optimal. Now, this is an algorithm which has been published in the Journal of American Society of Echocardiography in 2017 to evaluate cases suspicious of severe AS. Obviously, we are going to confine ourselves to the low gradient branch. And there are 3 important checkpoints. One is measurement errors got to be ruled out. Second is you got to define the flow status. And third is to assess the LVEF. So first step is going to be ruling out measurement errors. Precise measurement of LVOT diameter is of paramount importance. A small change in diameter will give rise to a huge change in the cross-sectional area. The shape of LVOT is not circular, it is elliptical. So 3D LVOT planimetry, whenever feasible, is always desirable. And Doppler alignment with blood flow got to be parallel. increasing intersect angle, worsening underestimation from 20% to 60%. We have just ruled out all the measurement errors, but still we find the discrepancy persists. Valve area is less than 1 square centimeter, gradient is again less than 40 millimeters of mercury. Now, other measures are going to be 3D assessment of the aortic valve. This can be either real-time 3D TEE, or it can be using the zoom function, or even using the full volume function. Using the MPR reconstruction, you can assess the aortic valve area. Still, we find it's less than 1 square centimeter. Now, third parameter is going to be dimensionless velocity index. The advantage is going to be this does not rely on the most commonest source of error, which is LVOT cross-sectional area. Simple and reliable, value less than 0.2 implies severe aortic stenosis. Here we find that the value is less than 0.2. So our patient has low flow and low gradient, and we have ruled out all the measurement errors also. So the next step is going to be you assess the flow or stroke volume index with a cutoff value of 35 mL per meter square. So it is obviously less than 35 mL per meter square. We are handling a low flow and a low gradient. A word about normal flow and low gradient. Is this really possible, a patient to have a normal flow and a low gradient? This is related to the inconsistency in the guidelines criteria. Here we see under conditions of normal cardiac output, a valve area of 0.8 square centimeter only corresponds to a gradient of 41 millimeters of mercury. But a valve area of 1 corresponds to a gradient of 26 millimeters of mercury. Now the clinical implications are these patients do not have truly severe AS, but the take-home point is these patients have a better survival with valve replacement compared to conservative management. A report from Mayo Clinic study says, irrespective of the valve gradients, any patient with aortic valve area less than 1 square centimeter has a better prognosis with valve replacement compared to medical management. So we have assessed the low flow and low gradient. Is it going to be classical or paradoxical? The answer is here. Ejection fraction is obviously more than 50%. We are handling a paradoxical low flow, low gradient. So how to evaluate this patient further and proceed further? We have 3 checkpoints actually. One is you got to get the substantiating evidence that it is paradoxical LFLG, like you rule out the clinical causes for low flow and this low gradient, and also find out the LV geometry, look for any concentric remodeling, assess the systolic and diastolic function. The next step would be assessing the severity, whether it is severe or pseudo-severe, and final step is going to be risk stratification. So other clinical causes which can be responsible for low flow and low gradient are mitral stenosis, regurgitation, tricuspid regurgitation, abnormal RV function. Patient doesn't have any of those features, normal mitral tricuspid valves and normal RV function. So next thing is going to be, you got to assess the LV geometry. To look for evidence of concentric remodeling, he has a relative wall thickness more than 0.45, goes in favor of concentric remodeling. Again, a small LV cavity is obvious by EDD less than 50 mm and end-diastolic volume index less than 60 mL per meter square. Coming to the diastolic function assessment, all the parameters, the transmitral flow, pulmonary vein flow, the tissue Doppler, as well as the propagation velocity, the candidate ticks all the boxes for a restrictive physiology. Longitudinal systolic function, I have assessed MAPC and global longitudinal strain. Here we find that the MAPC is slightly on the lower limit of normal. A point to be noted is any reduction in MAPC, this correlates well with increasing evidence of fibrosis on histology as well as increasing values of valvuloarterial impedance. The next parameter is going to be global longitudinal strain. In this patient, this appears to be relatively preserved, that it's well above the cutoff values, but we got to see that there is evidence of mechanical dispersion here. Now, what is running in your mind is, why are we worried about the longitudinal systolic function? What's so peculiar about it? Any patient with increased afterload, it could be a hypertension which is long-standing, or it can be severe AS. It is the subendocardial fibers which suffer ischemia. And these subendocardial fibers are mainly responsible for longitudinal shortening. So we always find evidence of impaired longitudinal systolic function in these patients. This appears relatively early. And the other point is, ejection fraction depends on contraction of both the short axis and long axis. So obviously it remains relatively normal. So we have assessed a patient with bona fide paradoxical low flow, low gradient. So how do we assess the severity? There's a small change here. We are not going in for the dobutamine stress echo. It is that CT aortic valve calcium scoring, which is used to assess severity in patients with paradoxical LFLG with different threshold values for men and women. Here we see that the aortic valve is calcified, but I'm sorry, I don't have the precise cutoff values. We'll just assume it's a severe paradoxical LFLG. So final step is going to be, what is the risk assessment or risk stratification? Is he going to be a high risk candidate? For this, you got to look for evidence of fibrosis On MRI, this appears as late gadolinium enhancement. So we have a patient who is severe, symptomatic, paradoxical, low flow, low gradient. How are we going to manage the patient? Before we manage this patient, just a couple of slides about classical LFLG evaluation. The main difference between evaluating these two entities is mainly how do you differentiate severe and pseudo-severe. For classical LFLG, we still the dobutamine stress echo holds good, but the differences are going to be you start with a low dose of dobutamine like 2.5 to 5 mg. You ramp up very slowly every 5 minutes, and the maximum dose is going to be 20 mg per kg per minute. Three possible outcomes: valve area increases more than 1 square centimeter, pseudo-severe. Valve area remains the same, velocity and gradient increase, truly severe. There is no contractile reserve. There is no increase in stroke volume at all. This is no flow reserve. No flow reserve. It is just to estimate the operative risk. And the point to be noted is absence of flow reserve does not preclude aortic valve replacement. Whether patients have flow reserve or no flow reserve, the prognosis is always worse with medical management compared to valve replacement. So the implication is any candidate you have no flow reserve. First point is they have a higher operative mortality, 22 to 33%. And the next point is you got to resort to other methods to evaluate whether it is severe or pseudo-severe. The other thing in hand is aortic valve area projected. This is a novel parameter to assess whether it is severe or pseudo-severe. But the recommended one is again the aortic valve calcium score with different threshold values for men and women. So that completes the evaluation. Finally, coming to management, as I said, severe, low flow, low gradient valve, whether it is classical or paradoxical, from the 2020 ACC/AHA guidelines, it is a class 1 indication and no more 2A indication for aortic valve replacement. When I say aortic valve replacement, you have two wings actually. You can do either a surgical AVR or a TAVR. Surgical AVR, better survival compared to conservative management across various ejection fraction groups. Excellent durability for both the mechanical and prosthetic valves. And you have good improvement in functional status as well as overall survival, but should be very cautious to avoid patient prosthetic mismatch in these high-risk groups. But the prices, they have a higher perioperative mortality. TAVR, this is a very safe, effective, regardless of surgical risk, very few perioperative complications, greater LV recovery, early recovery to life, but its own demerits are paravalvular leak, need for PPI, valve degeneration. What do we do? Whether it is TAVR or SAVR, this has been a debate for decades, but most of the studies have been done in severe aortic stenosis, high gradient group. There are no studies which are confining themselves to low gradient. This is a meta-analysis of partner 1A, 2A notion in core valve. TAVR gives a good survival benefit compared to SAVR over a 2-year period. This is irrespective of the type of TAVR valve used, whether it is balloon expanding or self-expanding, across the surgical groups of both high risk as well as intermediate risk, and the benefits are more pronounced in female patients undergoing transfemoral TAVR. Now, this is one study which is a prospective observational study of 481 patients, but the thing is this is confined to low gradient aortic stenosis alone, whether it is SAVR or TAVR. Here we see two important points: SAVR or TAVR, significant benefit compared to conservative management. When you compare neck to neck, whether it is TAVR or SAVR, transfemoral TAVR, significant advantage over SAVR. This has significant advantage over alternative access TAVR. Now, as we know, for severe aortic stenosis, low flow, low gradient, the recommendation is AVR. But what do we do for pseudo-severe aortic stenosis? It is actually medical management. If there is no response, or if they face, in spite of it, they have persistent heart failure, the recommendation is AVR, but this is one trial which is underway assessing the role of AVR in moderate AS and reduced ejection fraction. So that is our patient findings. Diagnosis of paradoxical low flow, low gradient. He managed to undergo surgical AVR. To finally conclude, assess the valve morphology, recheck your peak and mean gradients, check the aortic valve area, assess the flow status, stroke volume index, assess the ejection fraction. Classical LFLG, dobutamine stress echo to assess whether it is severe or pseudo-severe. No flow reserve, it's only a high perioperative risk. Go for aortic valve calcium scoring to see whether it is severe or pseudo-severe. Paradoxical low flow, low gradient, misdiagnosed mostly, severity is underestimated, benefit of surgery is inappropriately delayed. Aortic valve replacement has a significant survival benefit compared to conservative management. But the problem with surgical AVR is a high perioperative mortality. TAVR provides an attractive option in feasible cases with high and prohibitive surgical risk. Thank you.